Dear friends, welcome to this new video. This is an unusual case of post-traumatic cataract following a blunt trauma that occurred over 20 years ago in this patient. So we have a very old traumatic cataract. The nucleus appeared quite hard in preoperative examination. There was no zonular laxity, and the patient was relatively young, so we decided to do a SICS surgery. For the scleral approach, we can use a superior traction suture to help. We perform a conjunctival dissection superiorly over almost 180 degrees with a superior nasal resection. Here, the local anesthesia diffused under the conjunctiva, which facilitates the dissection of tissues. So we cauterize a little and position ourselves about 1 to 2 millimeters from the upper limbus. We make an incision of about 9 millimeters. I think that's the right size to allow for easy and quick extraction of the nucleus. Once we have made a nice incision with a 45 degrees knife with the same depth across the entire width of the incision, now we're going to create our scleral incision plane. So we start quite quickly in the central part. We dissect up to 1 or 2 millimeters into the cornea. Then we will dissect laterally. We see a slight trace of blood in the cornea, which indicates that we have not perforated. It also helps to see a bit how far we are in terms of tunneling. As you can see, the scleral incision is 9 millimeters, but in the cornea we will go even larger. Next, we will work temporally in a less invasive manner initially, which will facilitate the rhexis. So we will stain the capsule with trypan blue dye. The rhexis will be a bit challenging because, since it's post-traumatic, there was some capsular fibrosis. As you can see, we see a sort of fibrous ring. Thus, the rhexis will be quite difficult with unusual tension areas due to the fibrosis. We will have to achieve a sufficiently large rhexis while ensuring it isn't irregular. At first, everything is going fairly well. We manage to create something quite clean. At the beginning, I make it small with large nucleus like this because it tends to run out. We manage to keep a more or less regular rhexis size. But as we reach the fibrosis, things start to get a bit unusual, and the rhexis tends to run out quite quickly. So we have to pull firmly towards the center. And there we have a little irregularity superiorly, so we wanted to widen the rhexis. However, since it tends to run out a little, we couldn't go too far. We'll finish with the 25 gauge needle, taking care to avoid a radial run out towards the posterior capsule. Once we've finished working on this capsule in a more or less satisfactory way, we can focus on the nucleus itself. There was also some white epinucleus that will be evacuated during hydrodissection. The importance of a large rhexis is to allow for much easier extraction of the nucleus and avoid overpressure during hydrodissection. Now we can perforate our scleral tunnel. I recommend entering with the side of the knife to avoid creating a second tunnel. Otherwise, it's harder to find the right incision. Then we will widen our incision on the sides with back and forth movements. We will create a trapezoid-shaped incision, larger in the cornea than in the sclera. It is really important to have this shape as it facilitates the exit of the nucleus, like a funnel. Once we have a relatively satisfactory sclerocorneal incision, we will do a bit more hydrodissection. We will protect the endothelium with viscoelastic, and I recommend using a dispersive viscoelastic at first because it tends to remain in the eye better, making it less likely to wash out. This is better for corneal protection. Then you can use the dispersive one. We will also protect the capsule with it, making some space to see better what happens when injecting. And this helps to remove the epinucleus that could obstruct visualization. After protecting the cornea and the capsular bag, we will try to progressively luxate the nucleus, either by doing a bit more hydrodissection or directly by mobilizing the nucleus in the anterior chamber. Typically, we use 2 Sinskey hooks to lift it gradually, little by little. There was still a little epinucleus, and the nucleus wasn't too dense after all, but it is sufficiently hard to be mobilized to favor a scleral approach. We re-inject a bit of viscoelastic on the iris to prevent it from coming out with the nucleus, and in front of the capsule to avoid it rising similarly when we extract the nucleus. So we catch our anterior incision border, place the Snellen ring, and just need to open wide and press a bit on the posterior incision border, and there it is. The nucleus comes out in one block. So we have managed to evacuate the nucleus. There was still a little bit of epinucleus left, but not much, and there wasn't really any cortex. We will directly insert our lens and will wash out the viscoelastic and the epinucleus at the end with the irrigation aspiration. It is quite easy to insert the lens given the large incision. It's a 3-piece lens for more stability, so we'll position it after aspirating all the epinucleus. The good thing about such an incision is that all the residues tend to come out easily, but the iris also tends to come out if you haven't sufficiently tunneled your incision. So, when it's like this, try not to force things and work a bit with hypotonia to push the iris back in. We will re-inject some viscoelastic to position the second haptic well under the rhexis and rotate the lens, ensuring that the haptics sit over solid rhexis zones. Once this is done, we can pre-place our suture. In reality, there's no need for sutures if the tunnel is correctly made. Here it was the case, but I like to add a small suture to tighten the cornea that has been relaxed by the incision. So, we suture, we wash, and then we tighten our suture. We only need to make a conjunctival stitch if we performed a clean dissection, and so we have a result that seems relatively satisfactory. That will be enough for this video. I hope you enjoyed it and see you soon for the next video.